Amongst the various complications of an AV fistula, one of the most serious one is dilatation or an aneurysm formation in an AV fistula. You can see it earlier on, but sometimes it is seen after the patient has been on dialysis for many years. I've got a patient who's been on dialysis for more than 10 years. It's the same fistula that was made, or in other words, the first fistula that she's ever had. But gradually it has increased in size, becoming what is known as a hose pipe fistula with an aneurysmal change. The reason it's called as a hose pipe fistula because the fistula vein, it increases in size, it becomes fibrosed, and it's firm. It's just like a garden hose pipe. So I'm going to show you what a hose pipe fistula is, and then on top of that, the aneurysms which have formed on the hose pipe fistula, as well as the stenosis and the collaterals which have also developed. So here we have, this is the fistula. This is where the fistula surgery was done more than 10 years ago. And here we can see that this is very, very firm. It's painless, but it's very firm. And this is what is called as a hose pipe fistula. Along with this fistula, you can see that there is an area of stenosis here. And this has led to an aneurysmal growth. So this is the aneurysmal growth with an area of stenosis. And this is a place where needles had been inserted for many years before the needle sites were changed. Now the needle is being inserted on one side, which is the only available side that we can get for a decent flow. Now, along with that, you can see that the vein is tortuous, and then this leads onto a huge aneurysm, which has got a very, very thin wall up above. And if you can just clearly see that, you can also see the pulsations here as well. After the aneurysm, you see that there is an area that is a bit narrowed, and this is called as the stenosed area. So you've got pre-stenotic dilatation leading on to, so this is the stenosis, this is the pre-stenotic dilatation leading on to an aneurysmal growth. Clearly seen beyond that, although there is the vein that has matured, but you don't see the vein as prominent as this one. The reason for that is because when you get this stricture or the narrowing, the blood flow automatically it drops. So when it drops, you won't get the same amount of blood flow as you get here compared to here. So therefore, you won't get that much dilatation as you've seen here. So this is a classic case of a hose pipe fistula. You don't see that in early fistulas. You see that after many, many years, and it really depends on how much blood flow there has been. And along with that, we see that there is venous engorgement, which is present on this side as well. Now, what this really means is that this fistula which was created, this wasn't an end to side fistula. This was probably a side to side fistula. There are two types of fistula creations that are made. One is called as an end to side, in which the vein is ligated from below and then it is joined with the artery. So this is called an end to side, the side of the artery and the end of the vein. And then you've got a side to side, in which the artery and the vein, they're joined side to side. In this case, you can get certain venous engorgements on this side as well. Now, the problem with these fistulas is that obviously we do have flows with the blood. So the blood flow will be inadequate. We'll run out of places where we can needle. But then there is always a risk that there is, unfortunately, there can be rupture of the fistula if something happens. Usually in the early stages, the skin, it covers it very tightly, and so therefore the fistula doesn't burst. But sometimes if there's an accident, for instance, if she bumps against something, then there is a real risk that this can rupture. So she's in the process of having this fistula ligate. Now this is going to be a major surgery because this is taking up a lot of blood flow. There's a huge pressure in this one, and so therefore this is going to be ligated. The vessel will be ligated. This fistula, hopefully in time, this will go down. The aneurysm rupture the risk will reduce, but the hose pipe will remain. The hose pipe will not go because that is fibrosed vessel. Now, out of modesty, I cannot show you what's happening up here, but the vein is engorged all the way here up to the neck and up to the ear as well, and you can actually feel the thrill on the other side. So she will have this fistula ligated and then have another one. While we are actually talking on the subject of fistula, just for your knowledge, there is a rule of 6. So just for your knowledge, there is a rule of 6 when you have an AV fistula, and the rule of 6 says that at 6 weeks, The fistula vein, it should be 6 millimeters in diameter. The depth should not be greater than 0.6 centimeters. You should have a 6 centimeter area where you can needle where you can place 2 needles, and the fistula should be able to take up 600 ml per minute of blood flow. So there we are. We've got a rare case of a hose pipe fistula with aneurysmal growths, aneurysm formations. It's just like I've got a balloon here. So you've got, this is the aneurysm, and you've got a post aneurysmal stenosis, and it was actually the post stenosis which actually caused the aneurysmal growth. The trouble is that she will not be adequately dialyzed. If you dialyze, you place a needle here, the fistula is at risk, the aneurysm is at risk, you won't get a decent dialysis because blood will recirculate inside this aneurysm. So we have to place a needle here beyond the aneurysm. So this is going to be the return needle, and the needle through which we take the blood, which is called as the arterial needle, is the one which is going to be placed beyond.